Test, test, test. Okay, gang. It is time to get started. I was asked to present to you an option. So the next exam is the 23rd, and several other people had exams, competing exams on the same day. That's the case for how many of you? Okay, if it is, could you put your hand up so I can see how many people have competing exams? 1, 2, 3, 4, 5. Okay. Let's see. So if we move the exam, we'd move it to the following Monday. That would be the 24, 25, 26. Who is in favor of changing it to the 26th as opposed to keeping on the 23rd? Show of hands. Those of you violently to moderately opposed to that, hands up. Okay, then the exam is moved to the 26th of April. 26th of April. Very good. Okay, we are talking about heart failure. And then after this, we'll get into anticoagulants. Then from there, we'll go to painkillers. So that's the superhighway we're hopefully traveling on. We're going much slower than I'd hoped we go, but hey, can't have everything. All right. Hope you guys enjoyed the yucky weather this weekend. And hey, John, when I left, you guys had just clawed back 4 runs from Bethel. And what's his name struck out on a high fastball. And then there was another inning. What happened the other inning? I had to leave. No, you guys were down like 5 runs. It was 10-5. Then you guys got 2 home runs in a row. You lost that game. Okay. It was close. It was close. And the relief pitcher, he gave up a home run, but he pitched a good game. So, yeah. Okay. Let's have a word of prayer, then let's get started. Father, thank you for today. Thank you for every student here. Watch over us, please. Help us to stay well. Help us to live smartly. Remember, hands, face, space, ventilate, and now vaccinate. Thank you for students who signed up to get their jabs. We pray, Lord, that they would handle them well, not have too many side effects. In Jesus' name, amen. Okay. Okay. Digitalis or digoxin. Now, digoxin is derived from the digitalis plant. If you don't know what digitalis is, foxglove. And have you grown foxgloves in your garden? They have spiky flowers that come up. They come up every 2 years. They're quite pretty, but don't eat them. They're deadly because they're full of digitalis. So digoxin, your mnemonic for digoxin is an ox digging a hole. Dig oxen. Get it? Ha ha ha. Digoxin. See, you'll never forget that one now. So this interferes with the sodium, potassium, ATPase. Sodium, potassium, ATPase. And since you have more sodium inside the cell, you can exchange that with calcium. You get more calcium inside the cell. More calcium in the cell, the more powerful your contractions. So this raises cardiac output. Raises cardiac output by raising the force of contractions. By raising the force of contractions. So this drug helps you pump more blood. It helps you pump more blood. That's the way it works. This drug, however, is a colossal pain in the butt because it has a lot of side effects and it has a narrow therapeutic window. So let's go to our little makeshift blackboard here. Oh, by the way, some of you occasionally ask me this. We had a quiz this last weekend. My team took third. Both the quizzes they lost by one question. And then my newcomer joined with a quizzer from West Branch. They took second, and then he took second in individuals. So go newcomers. And yeah, we have our regional final next month, and that's the whole book of John. So pray for us. That's a lot of material. Okay. So digoxin has a narrow therapeutic window. And if you need to remember this, think of the ox digging a hole next to a shed with a broken window. The window's broken. Narrow therapeutic. Okay, it's stupid. I know. Corinne, don't look at me like that. I know it's dumb. It's meant to be dumb because then you'll remember it. So the narrow therapeutic window. The therapeutic levels of digoxin, for those of you who are interested, are 0.8 to 2.0 nanograms per mil. If you're outside that, you are outside the therapeutic window. If your levels are higher than 2.4 nanograms per mil, that's your toxic level. Gang, that is narrow, very narrow. So you kind of use it for chronic heart failure. Oh, got the hiccups today. And it is most useful for those individuals that have some sort of atrial dysrhythmia, atrial arrhythmia. So it's good for chronic heart failure with atrial arrhythmias. Now, why the atrial arrhythmias? Well, the drug you see is going to have parasympathetic effects. Those parasympathetic effects are built around the fact that this will inhibit the sodium potassium ATPase of parasympathetic nerves. Because of this, the part of the heart that is more richly innervated by the parasympathetic nervous system will feel the effects of this drug more acutely. And guess which part of the heart is more richly innervated by parasympathetic nerves, the atria. Therefore, you will get decreased heart rates usually with digoxin because of that. So it's good for things like, if we go back up here, it's good for atrial flutter. Also good for atrial fibrillation. It's good for both of those. Now, this drug can relieve symptoms of heart failure. Research has shown it does not reduce mortality. So the usefulness of this drug is limited. So you get a reduction of symptoms, but your mortality stays the same pretty much. And it's got a whole truckload of side effects. Let's look at those truckload of side effects. Okay, AEs means adverse effects. Adverse effects or side effects. Same thing. All right, first thing you get are gastrointestinal disturbances. So you get things like nausea. You get things like vomit. You can also get diarrhea. And you can get anorexia. What's anorexia? Right, no appetite. You don't want to eat. You just food, because your stomach's upset, you don't want to eat. Okay, so that would be thing one. That'd be GI disturbances. The other one is you can get EKG abnormalities. So if you have a patient on digoxin, it's worth hooking electrodes up to them, taking a look at their ECG. So you can get T wave changes. You can get a short QT interval. You can get ST depression. And you can get other types of arrhythmias as well. And the arrhythmia that tends to be most common is pre-ventricular contractions. Now, having said that, you can get just about any arrhythmia from digoxin toxicity, but PVCs are definitely the most common. Now, because you are activating, you're stimulating the vagus nerve, digoxin can also cause bradycardia. And in some people, it can cause a heart block. Bradycardia also and a heart block. Now, the big thing you need to watch too with digoxin is the fact that you're leaving all that potassium in the blood. So you can also cause hyperkalemia. And this drug is lipid soluble, so it crosses the blood-brain barrier. If it gets into the brain, you can get neurologic symptoms. Anytime a drug causes neurologic symptoms, older patients will be more susceptible to it than younger patients. So you can get things like confusion. You can have disorientation. These are the sorts of things you might see. And then, of course, you can have visual disturbances, the big one being xanthopsia, where things look yellow. Things look yellow. So things look yellow. That's xanthopsia. Other thing about digoxin, it's excreted in the kidney. Therefore, what about drugs that prevent digoxin excretion? If drugs prevent digoxin excretion, digoxin levels are going to rise. They're going to become toxic. Because remember the broken window? You have a narrow, what's it called? Therapeutic window. Remember the broken window. So, what kind of drugs inhibit digoxin secretion from the kidney? Turns out to be a long list. Let me give you a short list. So the first of these is diltiazem. So diltiazem is a calcium channel blocker. Can a heart patient be on diltiazem? Sure they can. If they're on diltiazem, it's going to raise digoxin levels. Also, verapamil, same class as diltiazem. So can quinidine. Quinidine is a class 1A antiarrhythmic. They might be on that too. So can amiodarone. This is a class 3 antiarrhythmic. These drugs here, again, this is a short list. They decrease renal clearance of digoxin. And as we said before, if digoxin toxicity becomes an issue, you have this intravenously administered antibody. These antibodies will bind digoxin and will render it inactive. There's also, if you get arrhythmias due to digoxin toxicity, the treatment for that is intravenous lidocaine. Yes, lidocaine is a topical anesthetic, but if you give it intravenously, lidocaine also is a class 1B antiarrhythmic and is the treatment of choice for arrhythmias caused by digoxin toxicity. And this shows you one of the products that, this is Digifab. There's also Digibind. Digifab and Digibind are two commercially available antibodies against digoxin that will bind it very quickly inside the blood and render it inactive. All right, questions about our ox digging holes digoxin? Josh. Lidocaine. Lidocaine. Which Greg's not here, but lidocaine is a dentist's best friend. And lidocaine is always administered locally. You never give an IV of lidocaine unless you're using it as an antiarrhythmic. Now, in cases of acute heart failure, if, for example, you have a patient that's suffering from something like cardiogenic shock, cardiogenic shock might be due to electrolyte disturbances. They might be due to a blow in the chest. Who was that baseball player? John, help me out here. There was I think it was a shortstop or a third baseman. He took a ball straight to the sternum, and he actually went into cardiogenic shock. Evan, dude, I can't remember the name of the guy, but that was an example of cases where you can go into cardiogenic shock. So in that case, the heart needs a little kick in the pants, essentially, to get it running so that it will supply blood to all the organs. And in this case, you're going to use a group of drugs called inotropic agents, inotropic agents. Inotropic agents increase the force of contraction and or they increase the rate of contraction. They'll do one or the other or both. They do that by activating the sympathetic input to the heart. Therefore, they mimic sympathetic input to the heart, so they're called sympathemimetics. Sympathemimetics, because they mimic sympathetic input. Sympathemimetics. That's a bit of a tongue twister, isn't it? So there's two drugs in this group. There's dobutamine and dopamine. Don't confuse these two drugs. These get confused in the hospital because they sound similar and their dose is very similar. They have different effects. Dobutamine tends to activate the force of contraction. It has only modest effects on heart rate. It increases the force of contraction. This drug is called Diuretics, or just dobutamine as a generic. Then there is dopamine. Dopamine will tend to activate. Dopamine actually has two different effects depending on the dose. There's a very low dose of dopamine where it acts as a diuretic. Tons of research has shown low dose dopamine does nothing in cases of shock, so it's not used. Moderate dose of dopamine increases heart rate. Higher doses of dopamine cause vasoconstriction and increase rate and also raise blood pressure, which if you're in shock, that's a good thing. So let me repeat that. Dobutamine will increase the force of contraction. Very modest effects on heart rate, and some people it won't affect heart rate at all. That's dobutamine. Dobutamine is a beta-1 agonist. Therefore, beta blockers will work against dobutamine. Dopamine at the lower dose will increase heart rate. At the higher dose, you'll get vasoconstriction. So it'll actually raise blood pressure and raise afterload. That can be useful in cases of acute heart failure, like if your patient has sepsis or cardiogenic shock or something like that. Now, if your patient has angina, these can make it worse because they're going to increase the oxygen demand of the myocardium. Other than that, these drugs can be useful. They're not meant to be used long term. They're meant to be used for a time and then you get them off them. Oh, questions about this sympathemimetics? They're for acute cases only. Diuretics. Heart failure patients will retain fluid. That fluid is going to increase your preload and will increase the afterload and will exacerbate heart failure. Consequently, you want to decrease fluid, so you're going to put them on diuretics. Now, there's literature that shows that your potassium-sparing diuretics decrease mortality. They decrease mortality robustly. All diuretics will decrease mortality, but the stars of the show for people with heart failure are the potassium-sparing diuretics. So those will be usually your first drugs of choice. If you need more than that, then you may go to a loop diuretic or a thiazide. But all heart failure patients will be put on some sort of diuretic. Some sort of diuretic. Remember, loop diuretics are more effective than thiazide. But it depends upon their level of water retention, fluid retention. I remember I was on the plane once and they do that thing. Well, do you want to sit in the can't get candy? If you're sitting in the emergency aisle, which I love the emergency aisle, all that leg room, oh, please put me there. And so can you, are you okay with the instructions that you read here? And one chap, he was in a business suit, he said no, and he got up and he wanted to switch seats. So I said, oh, let me, please. And as I was getting up, I looked down, I noticed he had this support socks on his legs. And I said to myself, that's for people with swollen ankles. I'll bet you this guy's got heart failure. And so I switched seats, and then I saw him pull out some tablets and put them into his mouth, and I recognized the tablets. Okay, yes, I'm nosy. I recognized the tablets by their shape and the writing on them. He was popping a nitroglycerin. So I said, yeah, this guy's probably got heart failure. And then, as I was getting off the plane, he was on the phone. Turns out he's on the phone with his doctor, and he's talking much more loudly than he should have been. And he talked about his digoxin. And I said, yep, he's got heart failure. And so that's just an illustration of how nosy I am. But also that heart failure patients will retain fluid. They'll tend to retain it pretty badly. It can make them really uncomfortable too. Have you heard of what's called pitting edema? Okay, so pitting edema in heart failure patients will usually be in the ankle. Yeah, you stick your thumb, or you could stick your hand. You stick your finger in there, pull it out, and your thumbprint remains. And it'll remain there for a while. And that's due to fluid that's built up in the tissue around the lungs, the ankle, the tissue. That's the most acute place because of gravity, is in the ankle. And before you have surgery, usually your doctor will take your ankle and go, the doctor's not cupping a feel. The doctor's looking to see if you're retaining fluid, because that says you have a weak heart. If you have a weak heart, you have to treat your anesthesia completely differently than they do if you don't have a weak heart. Questions on the diuretics? We covered diuretics before. You know the side effects and so on and so forth. Okay. ACE inhibitors. ACE inhibitors, if your patient can tolerate them, are a must. These drugs will improve symptoms over 4 to 12 weeks. Several very large, very well-controlled studies show they decrease hospitalization. They prolong survival, which is to say they decrease mortality. and they decrease remodeling of the heart. Very useful. And you know how they work. We talked about that already. You know the side effect profile. The thing you have to watch really is that potassium level, a set of potassium levels. No ACE inhibitor seems to be superior over the other when it comes to heart failure. However, these two, lisinopril and perindopril, are not FDA approved for heart failure, but they are used. But if they're used off-label. If they're used off-label. Many of these are in generic and are relatively cheap. Angiotensin II receptor blockers are also very good drugs. They work about the same as ACE inhibitors. They reduce mortality. Their tendency to cause angioedema is much lower. They can cause hyperkalemia as well. That's the big thing you have to watch for, but they have the same advantages as ACE inhibitors. The two that are approved for heart failure are candesartan and valsartan. Candesartan and valsartan. Others are used off-label, but they seem to be equally effective. Unless contraindicated, all systolic heart failure patients will be on a beta blocker. They cause a 30 to 40% reduction in hospitalizations. They decrease mortality. They decrease symptoms. With all these drugs, you start at the lowest dose and you titrate up. You may not see full clinical benefits for a while, but you will see them. It may take 3 to 6 months to see benefits, but they will come. These are the ones that you're going to use. This is a list you should be well familiar with by now. Carvedilol, bisoprolol, metoprolol. If you use metoprolol, you have to use the extended release form. That's the one that's the best tolerated, works best for heart failure patients. Nebivolol tends to be used more in the hospital. You don't tend to use nebivolol quite so much, but it's used mainly in the hospital. If your patient has had a heart attack, that norepinephrine coming from sympathetic nerves is very toxic to the heart. So beta blockers slow down the heart rate. They're going to reduce blood pressure. They'll reduce your afterload. They're cardioprotective. They slow progression of heart failure. They reduce mortality in both moderate and severe heart failure. So they're very important. It's important to use one that's cardioselective, because if you don't, you'll tend to get your bronchoconstriction. They can cause bradycardia. They can cause or exacerbate AV blocks. And they can also cause something called acute cardiac decompensation, where the heart can't beat strongly enough to be able to support the tissues. So the patient has to be watched. Aldosterone antagonists, again, spironolactone is probably the one that's been studied the most, but a milrinone has also been studied and has been shown to have very, very positive beneficial effects in cases like this. These will increase salt and water excretion. They decrease mortality. They reduce hospitalizations. You just really have to watch potassium levels. Anti-androgen effects are more pronounced with spironolactone than they are with milrinone. If you get anti-androgen activities, you can switch. Milrinone is a bit more expensive than spironolactone. Spironolactone is very cheap, but they work about the same for heart failure patients. There's just more data on spironolactone. Some patients with heart failure experience pulmonary arterial hypertension. The reason for that is that the increased sympathetic input to the heart to get it to beat faster so to support your tissues causes pronounced vasoconstriction in the arterial trees of the pulmonary tract, of the pulmonary vessel tract. That can put a lot of pressure on the right side of the heart. That can cause right-sided heart failure. So to fix this, you can use agents that will cause vasodilation of the arterial tree in the pulmonary system, in the pulmonary circulation. There's a group of drugs for this. One group of drugs that will do this are actually the phosphodiesterase 5 inhibitors, like Viagra and like Cialis and drugs like that. Those drugs work well for this. Another group of drugs that will work for this are these drugs that end with ENTAN, ENTAN, NTAN, NTAN. And so there's bosentan, which is a drug that's been studied the most in patients with heart failure who have pulmonary arterial hypertension. And again, I'm the king of dumb mnemonics, but when you're out getting a suntan, you take a deep breath. That's how I remember those drugs, because they end in tan. And so bosentan. Yes, Elena, go ahead and laugh. Yes, I'm dumb. Go ahead, laugh. She's sitting there with her head down saying, I can't believe this guy. So bosentan, there's also other members in this group. They're not used as much if you have heart failure. This is the one you'll use, bosentan. Bosentan antagonizes receptors for a peptide called endothelin. Endothelin. Endothelin is made by the lungs. When the lung says, come on, heart, I need more blood. Come on, heart, I need more blood. Okay, here's what I'll do. I'll take these arteries and cinch them down. That'll increase the pressure. So squirt more blood to me and kind of defeats purpose, but that's what happens. These drugs antagonize those endothelin receptors. There's two of them. They're called ETA and ETB. And this antagonizes both ETA and ETB. Relaxes those vessels, decreases pressure on the heart, and you can breathe more easily. Very useful drug. This drug is given usually parenterally, and you can see there's some metabolic pharmacokinetic issues that you want to watch for if you're on other drugs that are metabolized or inhibit those particular cytochrome P450s. Now, there's a group of vasodilators that are very useful, especially in African American patients. This particular drug combination of hydralazine, which is an arterial vasodilator, and isosorbide mononitrate. This combination works really well in African American patients. They tolerate it well, and it decreases mortality. So the isosorbide mononitrate dilates veins and arteries. Hydralazine dilates arteries. So you decrease preload and afterload. Take a lot of pressure off the heart. And this particular drug combo is called Bi-Dil. Bi-Dil. Capital B-I, capital D-I-L. Bi-Dil. Or Biddle, if you're, that's what they tend to call it in the South, Biddle. So, stupid way to remember this. You want the pressure to be little, so use Biddle, because it rhymes with little. You have little pressure on the heart if you use Biddle. Biddle rhymes with little. Equally stupid, but again, if it helps you remember it, then use it. I don't say Biddle, I say Bi-Dil, but hey, if Biddle helps you remember it, I don't care what you call it, as long as you call me for dinner. Okay, hydralazine, the way it works, still not clear. But nitrates, you'll remember, work by increasing the amount of cyclic GMP inside vascular smooth muscle cells. That causes them to relax. You get dilation. That dilation is very good, and this drug reduces mortality. And if your patient cannot tolerate ACE inhibitors or other types of drugs, this is your next go-to. Now, hydralazine can increase cardiac output because you get reflex tachycardia, but your patient's usually on beta blockers. That's going to block that. Also, it can cause fluid retention. You're on diuretics. You don't care about that. So these two, you're affected. The biggie is that long-term use, you can get kind of a lupus-like condition. That lupus-like condition will go away once you get off the drug, but a percentage of people will start to get this lupus-like condition. You get antibodies against ANA. So the first manifestation of lupus is a rash across the face, and it's a so-called butterfly rash. And then lupus can affect any organ in your body. Kidneys, heart, liver, joints, it depends. This again will go away when you get off the drug. So some people can be on it long-term and never have trouble. So depends on the patient. But again, if you need something that will dilate your vessels and give the heart a little kick in the backside, this is your drug. It's used for acute purposes. This is called milrinone. Milrinone. So this drug is an inhibitor of your phosphodiesterase type 3. That's going to prolong cyclic AMP levels inside cardiomyocytes. That means they'll contract more forcefully, and they'll contract faster. To increase contractility of cardiomyocytes, and you get vasodilation at the doses at which you normally use it. If you use it at higher dosages, now it's going to inhibit cyclic GMP, phosphodiesterase 2. You're going to get massive dilation. Your blood pressure is actually going to crash. So be careful. If you just want the heart to beat faster, that's fine. But be careful with this drug if you start to use it at dosages that are too high. It can cause arrhythmias. You use it IV. In chronic heart failure, it can actually increase mortality. So it tends to be used for acute purposes. And its most useful purpose is really for cardiogenic shock, people with sepsis, things like that. Now, another compound you can use to also prolong vasodilation is a drug that will act like a version of brain natriuretic peptide. Brain natriuretic peptide increases excretion of sodium and water by the kidney, and it causes vasodilation. This is going to antagonize the effects of angiotensin II. So this will be used for acute decompensated heart failure because you're vasodilating, you get more blood to organs. This has been given IV. It's very good for improving breathing in patients with congestive heart failure. So this gets used a lot in hospice, actually, if a patient is dying of congestive heart failure. Can cause some renal damage potentially if it's used too much. Might increase mortality under some conditions. Has a duration of 18 hours. It's only given intravenously. And this is good if you're just trying to vasodilate things to let the heart essentially pump into more vessels more easily. People with heart failure, they can show a condition called orthopnea, where when you lie down, fluid will start to accumulate in the lungs and you'll have trouble breathing. This can relieve that. That's one of the usefulnesses of this drug. Nesiritide. All right, now this drug, combination drug, Entresto, is a combination of two drugs, valsartan and sacubitril. Valsartan and sacubitril. Valsartan, you know, it's an ARB. Sacubitril, what's sacubitril? Sacubitril inhibits a peptidase called neprilysin. Neprilysin degrades atrial natriuretic peptide. It degrades bradykinin. It degrades C-type natriuretic peptide. It degrades brain natriuretic peptide. So all these peptides that cause vasodilation, neprilysin degrades. If you inhibit neprilysin, what do? You vasodilate. You vasodilate substantially. You decrease preload. You decrease afterload. You give your heart a prolonged siesta. When this drug first came out, the original data on it was extremely exciting. Now, in just 2 years, this drug is the mainstay of heart failure treatment. So this is one of the pillars of heart treatment. You inhibit the renin-angiotensin aldosterone pathway. This, in fact, is that one leg usually. If they can tolerate it, you put them on Entresto. So this now is your first go-to drug, in addition to your beta blocker, your inhibitor of your diuretic of some sort, usually a aldosterone inhibitor, and then your SGLT2 inhibitor as well. All right, so the Paradigm heart failure trial was the trial essentially that showed you that this showed overwhelming superiority to enalapril. And enalapril is a good drug to put a patient on if they have heart failure, But essentially, by putting them on Entresto, you increased the benefits immensely. So this now really is your go-to drug, Entresto. And it's still under license, so it's still expensive, but cardiologists are waiting for the day when it gets to generic, then it'll be a lot cheaper and they can put a lot more patients on it. And the drug company that makes it also has a program for patients who can't afford the drug at all. Okay. Did everyone get the handout I sent you last night? Did you get a chance to print it out? All right, before we leave congestive heart failure, if you have the handout, please look at page 3. Page 3 of it. You'll see 3 drugs listed there that end with gliflozin. Gliflozin. So these were originally developed for type 2 diabetes. These are sodium glucose cotransporter 2 inhibitors, or SGLT2 inhibitors. These work in the kidney. They prevent reabsorption of glucose and sodium. So you excrete more sodium and more glucose into the urine. So they increase water, sodium, and glucose loss. You could see why they would be useful for treating diabetes. They lower blood pressure. They lower serum glucose levels. So these all end in gliflozin, canagliflozin, empagliflozin, and dapagliflozin. These are all under license. These are newer drugs, Invokana, Jardiance, and Farxiga. When these drugs were studied, it turns out that type 2 diabetic patients on these drugs fared far better than people who are not on these drugs. And the difference was the health of their hearts. Patients not on these drugs had a much higher tendency to have heart failure. Those on it tended to have their hearts protected. So cardiologists said, let's try giving these drugs to people who are not diabetics who have heart failure. And lo and behold, the data showed that these were extremely useful in patients with heart failure. Now they become that 4th pillar in treating heart failure. So let's rehearse those pillars again. Beta blocker. You inhibit the RAS system. Entresto usually. Diuretic. Usually spironolactone or flurinone to inhibit aldosterone, and then your SGLT2 inhibitor. Those 4 pillars hold up now the modern algorithm for treating heart failure. And because of this algorithm, patients with heart failure are living longer, they're experiencing fewer hospitalizations, and they're having less symptoms, which are all good things. These hypokalemia, but a lot of the drugs you're giving tend to increase your potassium. So hypokalemia is the most common. The other is the fact that you're excreting glucose. You can be at risk for genital infections. Just make sure the genital area is kept very clean. And then there might be increased risk of fractures, other things contraindicated in those with bladder cancer. Allison? Yeah. Yeah, pretty much, or a VAD, a ventricular assist device. might also be the other thing that they might need. People on VADs, it buys them time, but their number is going to be up pretty soon. Heart transplant really is your best bet in that case. Any questions about the treatment of heart failure? Any of the drugs? Oh, there's a drug at the end of your handout, Versaguat. Versaguat is very new. And this is an oral soluble guanylate cyclase stimulator. You can see it reduces hospitalization. This drug is under license, so it's very expensive. There's just not a lot of data about this drug. So this drug is new. People are using it, but there's just not much data on it. It was approved by the FDA the end of last year. So in the hopes of giving you the most up-to-date information I can, I included it, but there's really not a lot of long-term data on this drug yet. So seems to be well tolerated. Very good. And if there are no questions, we will soldier on. And now for something totally new. Let's take a look at blood drugs that are used to inhibit coagulation. Coagulation has two arms. You have platelets in the bloodstream. Platelets will undergo change, they'll clump together, and they'll form a platelet plug, a platelet plug. We are animals whose blood system is under high pressure. A platelet plug won't last. The pressure will blow it out the blood vessel just like a ball being blown out of a cannon. So you reinforce that platelet plug with these stiff fiber-like proteins called fibrin. That's the second arm of blood coagulation, the formation of the fibrin reinforcing fibers. So we have drugs that inhibit the platelet side of the equation. We have drugs that inhibit the fibrin side of the equation. Drugs that inhibit the platelet side of the equation are used to prevent clots in arteries. Arteries. The drugs that inhibit the formation of fibrin are used to inhibit clots in veins. Are used to inhibit clots in veins. Let me say that again. The drugs that inhibit platelet activities are used to inhibit clots in arteries. So if you want to prevent a clot in a coronary artery, what do you use? Use an anti-platelet drug. If you're worried about clots in the vein, deep veins in the legs, DVT, deep vein thrombosis, now you inhibit drugs, use drugs that inhibit the formation of fibrin, the anticoagulants. Those are used to inhibit clots in veins. Veins. So platelets are the smallest of the formed elements in blood. Platelets form from a larger cell in bone marrow called a megakaryocyte. They bud from the megakaryocyte. They're cytoplasmic buds from the megakaryocyte, so platelets have no nuclei. Platelets cannot make new proteins. They can't express genes because they have no nucleus. They release serotonin when you get damage to a vessel. That will cause the vessel to constrict. They also secrete growth factors to maintain blood vessel wall integrity, they only survive 5 to 10 days. So they don't survive very long. They have to be constantly replaced. So platelets are called thrombocytes. Thrombocytes. If you have a lack of platelets, that's called thrombocytopenia. Penia. Anytime you hear penia at the end of a word, that means a lack of. A lack of. So thrombocytopenia means a lack of platelets. A lack of platelets. And these cells are made in bone marrow. They're made by this process called hematopoiesis, which we will get to on Wednesday.